So let's take a look at these two frontal radiographs of an adult male patient. The images clearly demonstrate the whole abdomen and pelvis. Right off the bat, what stands out is the striking gross distension of the transverse colon. The more proximal colon looks relatively normal, but as we move distally, the situation changes. There's stool in the normal caliber segment of the descending colon. However, I cannot visualize the sigmoid colon or the rectum, and I also don't see any gas in the small bowel. The wall of the transverse colon is thickened, which suggests that it's very edematous. Now, looking at the left 12th rib, there's an abnormality with an expansile lucent lesion located in the mid-portion of the bone. The lesion doesn't show any periosteal reaction or aggressive features. In fact, there's no clear matrix pattern within the lesion, which makes assessing for ground glass difficult because the overlying bowel is also involved. I would definitely want to magnify this section of the image to confirm there are no aggressive features and compare with any available previous imaging. If this rib lesion is stable and shows no aggressive features, then I'd lean towards an indolent lesion, something like an enchondroma or fibrous dysplasia. At this point, I'm uncertain if there's a unifying underlying diagnosis linking the bowel and the bony findings. But here's what we know for sure. The large bowel obstruction, along with the mural thickening, represents toxic megacolon. This is a surgical emergency. The etiology is likely inflammatory, ischemic, or infective in nature, and I would immediately discuss the case with the on-call surgical team to ensure prompt management. Switching over to the axial CT image, we can see multiple small locules of gas in the dependent portion of the colonic wall. This intramural gas is present within what appears to be the distended transverse colon, which, to me, strongly suggests bowel ischemia. Even if there isn't any portal venous gas or other affected segments visible, this remains a surgical emergency, and I would notify the senior surgeon responsible for this patient as a priority. They need to know these findings urgently. In conclusion, this is a case of toxic megacolon with intramural gas in an adult male associated with Clostridium difficile colitis. There's also an incidental finding of fibrous dysplasia in the left-sided rib. You may get asked by examiners why I consider this case such a critical surgical emergency, and the answer lies in the nature of the findings. Intramural gas, especially in the context of colonic distension, strongly implies infarction or ischemia of the bowel wall, which can be fatal if not treated urgently. In addition, toxic megacolon carries a mortality rate as high as 20%, and the gravity of this diagnosis must be emphasized to the treating team. It's important to explain clearly to the non-surgical clinicians and junior surgical staff how serious this is, as they may not appreciate the urgency based on radiographic findings alone. When thinking of megacolon, always consider the patient's clinical history, inflammatory bowel disease, or infectious causes like pseudomembranous colitis from Clostridium difficile infection. The presence of such conditions, alongside imaging findings of bowel dilation and intramural gas, flags this as a life-threatening condition.